Welcome, everybody. Hello, my name is Jonathan Fritz. I'm the Chief Innovation Officer for Chime. It's my pleasure to welcome everyone to today's Chime Innovation Beyond the Edge. This is a 12-part series designed to share creative problem solving in response to COVID-19 and highlight innovations implemented by your peers. Today's session is Geisinger Innovation During COVID-19. And I'm very excited to hear from a great friend of Chime, John Kravitz, one of the most innovative CIOs that I know. A special thank you to DrFirst, our supporter for today's session. We know that you're incredibly busy at this time, and so we really appreciate you joining us today. One quick question that I'll pose out there: why is Chime presenting this series? And we're doing this because change presents challenges. It presents problems, but also opportunity. Opportunity for creative problem solving. This is really the core of innovation. We want to celebrate the value and the good that comes from that. So many of the Chime members have faced significant challenges from sudden remote workforce, spinning up training clinicians on telehealth, infrastructure, resource constraints, and now and going forward, the next phase of this war, transitioning to new normal, and what does that even look like? From what I've seen, our members are some of the most innovative folks in healthcare and are really leading innovators. And that's what we're trying to do, is to highlight those leading innovators through this program. Before we get started with this presentation, I would like to cover a few details. Our session will have two main parts. One, the presentation from our speaker, and two, virtual roundtable sessions of 4 to 6 people, so everyone can have a candid discussion on the topic that was presented. First, we're going to hear a presentation by John Kravitz, the CIO at Geisinger. At the end of that time, we'll bring everyone back together to wrap up and review any outstanding questions and follow-ups. If you're unfamiliar with breakout rooms, that's okay. I'll give brief instructions prior to splitting participants into the breakout rooms. We'll have everyone muted during the session. If you'd like to ask a question, please use the chat function to alert the team. The chat window will appear on your right side panel. Also, we are recording this presentation. This will be saved and stored on the Chime site, so you can go back and review any details once we finish. Discussions within the breakout rooms will not be recorded. If you have difficulty listening to the live audio stream through your computer speakers, keep in mind that you can connect to audio via phone. If you need help with that or any other technical detail, please use the chat window to send us your questions. For those connecting via phone and computer, please message the host with your name and phone number. Our host will then merge your phone and computer connections. This is important because if they aren't merged, then your audio and your computer video will be in 2 different chat breakout rooms. Lastly, by attending today's session, you will earn 1 continuing education unit for CHCIO, CFCHE, and CHISL certifications. We really appreciate all those that have the certifications and attending these to get additional education. And we will review the attendee list following this session and distribute the CEUs accordingly. With that said, I'm going to hand it over to Kurt Hess, the Senior Vice President of Sales at DrFirst, to introduce our speaker for today. Both Kurt and DrFirst have been excellent friends of Chime. We appreciate the support as one of our Innovation Beyond the Edge series supporters and supporter for today's session. Kurt?
Thank you, Jonathan, and thank you to everybody that's on the call today. A little bit of a problem getting on, but I'm glad you've all joined. It is a pleasure to be with you. As Jonathan said, my name is Kurt Hess, Senior Vice President of Strategic Sales here at DrFirst. We are tremendously excited in our partnerships with all of the various Chime facilities across the country, helping keep e-prescribing going, medication history, patient safety at the highest level, as well as care coordination. So we're excited about that. And certainly COVID has changed all of our lives and will continue to change all of our lives for many months to come, I believe. That being said, it is my pleasure to introduce John Kravitz, the Chief Information Officer of Geisinger Health System here in my own state of Pennsylvania as well. John is the Senior Vice President and CIO of Geisinger, where he is responsible for the IT strategy growth, as well as Geisinger's advanced analytics platforms. John has been a longtime friend of Chime, member of Chime, and served Chime's board for 2 years. He now represents Chime as the board chair this year, and I think it's fair to say that he has had his work cut out for him given the circumstances that are surrounding us here in our country today. With that, John, I will pass over the controls to you, sir.
Thank you, Kurt. I really appreciate that. And thank you, everyone, for taking the time today to attend the session. I hope you find this information helpful. I'm sure it's not that much different than the work that's going on within your organizations, but we're very happy to share some of the findings that we've had, some of the areas that we've gone through, and we've done a lot of agile approaches to this. So, you plan things out in a very short window of time when COVID hits. And over the last 6 to 7 weeks, things have been very laser focused at our organization. I have to say, moving a lot of people to the work from home setting, telemedicine is a big factor for us, but doing different innovative approaches to delivering the services that we have both to our patients, to our customers, as well as to our employees and our providers who are on the front lines. And those are the real heroes, as everybody talks about. The providers are the people that are really fearless, and they get out there and they do their jobs, and they're very effective. And we certainly appreciate that in every healthcare organization in the country. So what I'd like to do is to start with a little bit of a background I'd like to cover. So we've done a number of different initiatives. And I have to say, we plan these very quickly, very short order. Some of these were planned ahead of time, but very tight time frame to get things accomplished. So, the redeployment of staff, we've redeployed about 13,000 people to work from home from our health system. So just a little background, as Kurt said, he's from Pennsylvania, and we are from the state of Pennsylvania, and we cover about 2/3 of the population in the state, or the territory of the state. I shouldn't say the population because it's not quite that high. But we do have an integrated delivery network at Geisinger. Consists of a health plan, which has approximately 550,000 members, a health system which has 13 different hospital campuses, over 400 ambulatory clinic site locations. We have 2 research centers. We're doing a lot with COVID research right now. We do a lot with genetics and genomics. We have about 200,000 patients genetically sequenced in our database. Our goal is to take it to 1 million and then 3 million, our population, over time. We also have a medical school with about 450 physicians in training, 4-year program, and we also have about 2,000 graduate students in various other areas that we provide that service. So, initially with deploying people to work from home, we thought we had this pretty well licked because we do get nor'easter storms in the wintertime with a lot of snow that kind of traps people for a couple of days. And, during that period of time, we were able to support about 6,000 concurrent users. Well, we've scaled up. We looked at our population, kind of thumbnail approach to this and said, well, we got about 32,000 people. About 1/3 of those can work from home because they're support personnel. So we scaled our systems up and we're able to support 13,000 without a problem. We do use Microsoft Office 365, where a lot of users are hitting that. That is in the cloud, although we do need multi-factor authentication to be able to get there. So our systems are very closely dovetailed to make this work for identity access management. We've had also, as many other organizations, so this is not earth-shaking or new, but trained and deployed a lot of physicians to be able to do telemedicine visits for the home setting for patients who have decided they are concerned about coming into the organization, being exposed to people that potentially have COVID in waiting rooms or in exam rooms or anything else. So we've really deployed a lot. It's ironic, before this, we were doing some telemedicine visits, but payers were not conducive to this. Medicare wasn't, and other commercial insurances weren't really paying for telemedicine visits, video conference visits. That has all changed with COVID, and hopefully that's a positive change for the future that continues on. We think it will. But we've actually deployed about 1,600 providers to work from home, to work with accessing patients in their home settings, I should say. Some do work from home to do it. Others do work from their offices, but they're socially distanced when they do that. So the ability for us to do that was really remarkable, I think, in a short order of time. Our systems have been fairly solid, a little rickety in the beginning, but we've got that stratified. It is a cloud-based vendor, which helps a lot, and we've integrated it right into our electronic health record system. But, you know, if you looked at things pre-COVID, say the beginning of March, the end of February, we were doing about 1,000 video conference visits a month. We are now doing approximately 2,000 to 2,200 a day, and we'll continue to do that. About 48 to 50% of our at-home visits now are video conference visits, and the other 50% are telephony. We've been seeing that number shifting to a point where we were at about 20% video and 80% telephony. We're now reversing that. We want to see that go all the way to 80% video and 20% telephony, if not 100% video over time. So, you know, we've got a solid system, I feel, in place. We have contingencies for that in the event we had failure. We have contingencies out there as well for access to the patients in very remote settings that have very poor internet access. So we're about to use that next. It is a solution that will augment our telemedicine solution and continue to be able to provide those services. We look at telemedicine as a very important, video conference telemedicine as a very important piece because the patients are very satisfied with that as opposed to a telephone encounter. Video conference allows them to see the provider can look at them, they can you know, do a fairly well physical exam via the telemedicine visit. So we're finding that to be really helpful, big patient satisfier, and it's helping us get over the hump until we can get back to normal operations. Now, what's important is we're already doing post-COVID planning. So Jonathan talked about the new normal. Well, we think the new normal will include a lot of telemedicine, a lot of people continuing to work from home. We feel that this is a process that's going to continue on well into the future, if not permanently. And so we want to get ahead of this and plan for it in our organization to be able to support other levels of care and services to our patients. So that's part of our process. We're going to talk about some of these with an analytics command center that we've established. We've also established a number of different bots to help us through COVID screening for our patients. Because of our patient population, we do have a heavily Hispanic population in parts of our service areas. So we've also provided a Spanish menu as part of this and communications in Spanish. And digital screening at all of our sites where we could track encounters, we could track the people that have come into the sites, whether it's a vendor. Patients are very restricted, but we still track the patients. And we have their contact information, and we're looking at contact tracing. So we're working through that process right now. Human resources for redeployment of our staff, and I'm going to talk about that briefly. We've redeployed quite a number of staff to other service areas as we closed down clinics because patients weren't coming into those clinics. So we've redeployed those staffs to other areas to support the patients that are in need and the staff members that are in need to provide different services. So those have all been deployed and we're successful at those. But we also have some things that are in process right now and fairly well along to ready to cut over to go live staff. And that is an employee health surveillance bot. We've been using that. It's been working pretty well. Contact recovery and rescheduling for our patients. Talk about that. And then employee shift screening on a mobile device. So a lot of this work has been developed on mobile, integrated through API integration, and it's the direction that we feel is the right direction for our organization. So moving forward, I'll give you an example of one of our tools from our analytics dashboard. This was our surge planning. We put a lot of work into surge planning. I report up to the Chief Operations Officer for the system, so all of our Chief Administrative Officers from every one of our 13 campuses are in these meetings and reporting, and IT supports all the work that we've done. You know, we've done a lot of tent work for screening and treatment, as others have. We've replaced those tents with heavy-duty tents that are actually they're heavy grade, and they are really meant to be able to withstand storms that are pretty severe. So all of that stuff has all the equipment in it that's necessary, kind of like a MASH unit, if you think about that from field hospitals. So similar services, similar connectivity, and really functional at a very high level. But this is an example of different analytics that we've done with modeling for surge planning. And you can see a bunch of our campuses here. This is not all. This is just a portion of about 6 that are shown here. But those campuses have, you know, limited, moderate peak, and severe peak. Fortunately for us, in our territory in northeastern Pennsylvania, we've got 3 hospital campuses up in the north, the Scranton, Wilkes-Barre area. And they've been most heavily hit at this point in time because of people traversing over from New York City and northern New Jersey that would commute back and forth into the city. So we've had a number of different exposures and positive testing COVID patients that have required inpatient services. And we've had our share of people passing on as well from this, especially people with, you know, elderly and multiple chronic disease conditions, very compromised immune systems, unfortunately. But this is just an example. We've done a lot of the modeling, worked with the University of Pennsylvania Health System and their modeling that's been developed through the university, and had leveraged that for some of the planning that we've done. As an example, this is our redeployment assistance. This is a bot that pulls information from our database, from our Lawson or Infor system that we currently have, that we're actually in the process of replacing with Workday. But we have integration into the Lawson system that pulls all the available employees so that they could be considered for redeployment. And of course, they go through a survey and answer a lot of questions, and then they tag themselves as available for redeployment within the health system. So they may go in to help in dietary, housekeeping, or nursing functions, sitting functions with patients, sitter roles, and things like that. There are a number of different opportunities for us. And this is just one of the automated tools that has a mobile application tied to it that assists us through this process. And as you can see with the graph on the right side, we have 68% are open right now, and 27 have been deployed. This is a little dated. I think it's just 2 weeks old. Our redeployment has been considerably higher. I think we've redeployed about 1,800 employees into other roles. Now, the interesting thing is, as the state of Pennsylvania releases our restrictions on elective surgeries or opening outpatient visits, you know, we will be going through a process of taking those people and bringing them back into their normal job functions. So the redeployment won't be as critical at that point in time, but we'll take all the necessary precautions for our patients to make sure that they are safe and they feel comfortable in this environment as we move forward, both for elective surgeries and in-person visits moving forward. Consequently, we do not anticipate telemedicine visits slowing down because we're starting to do inpatient visits. There is a lot of pent-up demand. People have been kind of, you know, put on the side unless it was an emergency situation for the last 7 to 8 weeks. So demand is there, and the patients are in need of our services. So we plan on continuing to move forward to support that. This is an example of another bot that we're using. It's called Syllable. And we utilize this for our screening when patients call in and they're going through all their symptoms and everything else before they get to speak to a nurse for triage. We take them through a bot process where they can answer information and questions. Now, if they're getting stuck, it'll transfer them right over to a live person. But we try to use this as much as possible to alleviate a lot of backlog and a lot of patients waiting on hold for a long period of time to speak to a nurse for our triage areas. And you can see there are certain times of the week where there are certain times or peak periods within. And so we're measuring actual calls per day, and then unique calls per day are in the dark shaded blue areas. So it's not unusual. From this couple of weeks ago, we were doing about 5,000 bot service calls per week. And that helps us considerably because we do get on average of 1,000 to 1,500 calls per day into this nurse triage location, so that they could then queue up people for testing if they do meet the symptom requirements and criteria, and get them scheduled into those tents for screening or treatment. We'll get to the ED depending upon how severely ill they are. We have an employee health surveillance bot as well. And this captures information for our employees because we really want to be careful that our employees are being screened effectively and they are providing services in a manner that they are COVID-free, so that patients that are in the inpatient facilities who have severely compromised immune systems or having challenges breathing and have a number of different apparatuses are not at risk from our employees. So we've done a lot with this. The bot captures symptom data, presents the employee for employee health. We have surveys that the employees take daily. They could do this on their mobile device before they even come into the facility. And what we are also doing next is we're going to be using infrared thermometers. We've ordered them. They hadn't come in yet. We expect them possibly by today or Monday, but we're going to start using that for all of our employees to make sure their temperatures are within range. We can do it very quickly as they're entering the facilities to make certain that no one's running a fever, chills, other issues that they can have, sort of shortness of breath, severe cough, stuff like that. And that's part of the criteria that we follow for our employees. So they are checked very regularly. We also were one of the 2 organizations in our state to be able to do the testing for COVID through our own laboratory systems. And so what we were seeing with the testing was we could do about 320 tests per day traditionally, but we are doing something new. We do have a new system coming in, an analyzer, and that will allow us, running on 2 shifts, to do 10,000 tests per day. So that's a big improvement for us. That'll help with supporting the population and getting the COVID tests done effectively, so we know how we could treat these patients or know who is required to be in quarantine, so to speak, to keep them from spreading the disease to other people. While we're coming back to normal, or starting to come back to normal, planning for it, we have people who have canceled appointments, and we have them all tracked in our electronic health record system. We could track whether they canceled for reasons of COVID or they were no-show for an examination. And what we do is we have tools that we use through our reporting workbench with Epic. And these tools are really helpful because they allow us to go through a process and look to see if anyone is scheduled in the next 90 days. We run through these algorithms, and we're able to produce lists to get to our patient contact center and start reaching out to patients to schedule appointments. We are also going, this is all ambulatory, we're going through a separate process for tiering for any kind of elective surgeries, looking at a tier 3 being the highest tier where people have an emergency situation. We've never stopped doing those kinds of surgeries, but we're continuing to look at that now in the outpatient settings as we have for the inpatient. We'll continue doing that and work through tiering of tier 3, tier 2, or tier 1. Tier 1 being elective, tier 2 is in between. And so we're working through that process now to get those folks rescheduled to get back in for elective surgeries and things like that. We're anticipating starting somewhere around middle of May 11th or May 18th for those procedures. So everything that we're doing, though, is not hurrying because of anything financially driven, although financially it is very disruptive to our system. We are looking at it from a patient, safety is top priority for our organization, and we will continue to drive with patient safety in mind. Financial is way down the line for us. So these are important things to consider. How many appointments we've had so far, and we continue to utilize the tools that are available to us to meet that need. We do have digital screening at all of our locations. So if a vendor comes into an organization because they have to work on a piece of medical equipment, they go through a screening process. We capture their information in a database at the door. We do checking, temperature checking, and everything else with them, and go through the whole screening process, including collecting their information and their contact information. We mentioned about contact tracing. We're well underway with that process, but we do not have it nailed down yet. We do this for vendors coming into organization or patient visitors that are permitted. It's a very restrictive visitation process right now. We, for the most part, have a no visitation except for our pediatrics hospital. Currently, I believe, has two parents are allowed to come in for the pediatric patient. And for maternal fetal medicine, I think it's one person at this point that's allowed to come in with the expecting mom. So they're all tracked. We go through this entire process for everyone. And we do this just for the safety and measure of our patients that are inside of our facilities and our employees. We do an employee shift screening. As I mentioned, a lot of new mobile apps that we've developed. And so this is another one where the employees are required, whoever come into the facility, every day they need to answer these questions and they need to be screened. Now, I did mention we're getting these infrared thermometers for all locations. So it's a very quick process to determine if an employee is running a temperature and potentially may be a COVID candidate to be tested. But we have these for every location, and if their status is green right now, they're allowed to come into the facility. Of course, everyone is masked and takes proper PPE measures within the organization. But normally I'd be wearing a mask, but I'm in my office right now. It's a little difficult to hear me talking through the mask. So I will be wearing it the rest of the day, guaranteed. But that's one of the processes that we follow across the organization. We're masked. Everyone is masked. Level 1 masks are required. And so that's been part of our challenge, is making sure we have large enough supply of those. But our procurement department works very judiciously at that to make sure we're meeting those needs. And so that kind of wraps up, the rest of what we've been doing so far. We have a lot of things that we're planning, but we don't have them in production state just yet. So I appreciate your time this afternoon.